Please go ahead.
Dina, thank you very much for the very kind introduction. And it's an honor to be here, and it's a real honor to follow Peter Davis in this session and join Charles in this session as well. Also, thanks to Nasreen for inviting us to this session. Can you all see my screen?
Yes.
Okay, great. So I will talk about oxygen and epinephrine, two of the topics that are really close to my heart, and also briefly talk about oxygen targeting during resuscitation, and address these two as to what might be changing with respect to these topics in the 8th edition of the neonatal resuscitation program that's coming out later this year. So here are my disclosures. Here is my funding. Over and above all of these, I want to mention that I'm a member of the AAP Neonatal Resuscitation Steering Committee, but the views and figures and other data that I show here are my personal perspective and do not reflect the official position of the AAP or the American Heart Association or the Neonatal Resuscitation Program. So I'll mainly focus on neonatal resuscitation and post-resuscitation care in the immediate postnatal period during the course of this talk. So we all love oxygen, and this is a drug that many of us use on a regular basis. Anytime you see a baby in the delivery room who does not look well, pink and cyanotic, we have a tendency to use oxygen. And those of you here who trained with me before the 2000s, we used 100% O2 for every single delivery, no matter what gestation, and that's what we were used to during that period. So we thought oxygen is the elixir of life, and we all love oxygen. So things changed a lot since then, and here is the latest version of the 2020 AHA guidelines that came out in October last year, where they gave us new guidelines for treatment of resuscitation of term infants, neonates with PPH, and doing cardiac compression following spontaneous circulation, and also in preterm units. And I'll outline some of these topics during the next 25 minutes. The question in every single situation here is, should we use low oxygen, usually defined as something between 21 and 30%, or should we use high oxygen, usually defined as something between 60 and 100%? So here are the guidelines that we were given, and to go through some basic abbreviations, COR in all these tables refers to class of recommendation, 1 being higher, 3 being harmful. LOE stands for level of evidence, R stands for randomized trials, LD stands for limited data, and I'll come to that in the next slide. EO stands for XP with regards to oxygen administration. In term and late preterm newborns, 35 weeks or more gestation receiving respiratory support at birth, the initial use of 21% oxygen is reasonable. And this is level 2A is the class, and the level of evidence is B, randomized. In preterm newborns less than 35 weeks of gestation receiving respiratory support at birth, it may be reasonable to begin with 21 to 30% oxygen with subsequent oxygen titration based on pulse ox. And this is 2B and C based on limited data. And finally, in term and late preterm newborns, 35 weeks or greater gestation, receiving respiratory support at birth, 100% oxygen should not be used because it's associated with excess mortality, and this is a harm that can be induced by using 100% O2 in term babies. And we all know this table that we are used to that comes with NRP suggesting what the target should be at various times of life, time after birth. So if you think of resuscitation in a term infant, you notice that fetal levels of PO2 are really low, and even using 21% O2, there's a decent, almost doubling to tripling of the PO2 levels soon after birth, even while breathing room air. And this small increase in PO2 can give rise to a subtle surge in oxygen-free radicals in the baby's blood and also in the lung following birth. This is something that happens normally and has happened to all of us. O2 can go as high as 350 to 450 millimeters of mercury, and this huge increase can lead to a huge surge in oxygen-free radicals. And Max Vento and colleagues have shown that these free radicals can last as long as 28 days in babies and can have long-lasting consequences. So What does 100% O2 do? We know from animal studies and also some human studies that use of 100% O2 for resuscitation can increase the incidence of HIE and cause brain inflammation, can cause myocardial damage and acute renal injury in some experimental trials. In epidemiological studies, it has been associated with childhood leukemia later on in life. And when you put all the studies together, it has been shown to increase mortality in babies. And based on these recommendations, Dr. Ola Saugstad and Max Vento, who have done a lot of work in this area, have suggested that in term infants, initiate resuscitation with 21% oxygen. But unfortunately, we do not have clear-cut guidelines for managing babies with known pulmonary hypertension, especially babies with congenital diaphragmatic hernia, as to what optimal oxygen should be when these babies are born. So if you have a baby who is born with congenital diaphragmatic hernia, if you have a baby who is born with congenital diaphragmatic hernia, nowadays we recommend delayed cord clamping. Some of the data in multiple centers, including Philadelphia, Denver, and France, and some from Australia, from Peter's group as well, have shown that delayed cord clamping might be helpful in this situation. And you do avoid bag mask ventilation, you intubate if needed, you place orogastric tube for suction, you tolerate pulse ox similar to other babies between 85 and 95%, and you avoid very high PIP. But what's interesting in this protocol from CHOP in Philadelphia is that instead of using 100% O2 that they were used to in the past for babies with diaphragmatic hernia, they started resuscitating these babies with 50% oxygen, targeting 85 to 95% pulse ox. If the baby had persistent bradycardia or cyanosis with SpO2 less than 80% at 5 minutes, then they went up on the FiO2 to 100% as needed. So here is their algorithm. You intubate and begin gentle ventilation with an FiO2 of 0.5. And then if the baby has bradycardia, after 30 seconds of ventilation, you increase the FiO2. If the baby's heart rate is good, you continue with an FiO2 of 0.5. And you check prerectal pulse ox at 5 minutes. And then if that's less than 80, then you increase by 10% and reach until you reach a pulse ox of around 85% or higher. On the other hand, if your pulse ox is at 5, or even wean as needed. In fact, in my institution, we actually start with an FiO2 of 21% and go up if as needed. But the interesting in the CHOP protocol that they noticed was that if a baby required increase in FiO2 to 100% with diaphragmatic hernia, that group of babies had a mortality of 30.9%, as opposed to babies who would continue on 50% O2 without a need to go up on oxygen. That group only had a mortality of 55.1%. So right in the delivery room, the need for higher oxygen dictates the degree of pulmonary hyperplasia and pulmonary hypertension and can give an idea as to what the mortality might be in that particular cohort. So this is something that's useful in babies with diaphragmatic hernia. So again, in babies with diaphragmatic hernia, we do not need to use 100% O2 to initiate resuscitation, and the use of either 50% or even lower oxygen might be adequate in this group. So the next question is, what should be the optimal target for babies in the delivery room? And the numbers I showed you earlier that are shown up here in this particular table are based on Dawson curves from Jennifer Dawson. The SpO2 and heart rate gradually increase over the first few minutes of life, and that's where these numbers are loosely based on. More recently, Max Vento and his colleagues did more studies in babies that were undergoing delayed cord clamping. And what they observed was that if this dark black line here are the Dawson curves for pulse ox, they showed this light blue line are the Vento curves for delayed cord clamping. They showed that for the first few minutes after birth, delayed cord clamping is associated with higher pulse oximetry values compared to the Dawson curves, and slightly higher heart rate values as well compared to the Dawson curves. So why does this happen? We know that when the placenta is still connected, some umbilical venous return is coming back to the baby, usually with a saturation of around 80 to 85%. At the same time as the lung is being established as the site of gas exchange, more pulmonary venous return is coming back to the left ventricle. And the combination of these two provides a stable LV preload and causes a more stable heart rate. But this transfusion can give rise to slightly high oxygen. The question as to whether the current guidelines that we have are adequate or whether we should use slightly higher targets based on the Vento curves, and that's something that needs further studies and further evaluation. So moving along, some of these babies, occasionally, very rarely, as Dr. Davis mentioned earlier, require chest compressions, and the current recommendations for chest compressions are a heart rate less than 60 per minute, despite adequate ventilation for at least 30 seconds with good chest rise. In this case, we do chest compressions, and when you're doing chest compressions, it is recommended that we use 100% oxygen. And remember, the level of evidence for this is 2B. It's relatively low and mainly based on expert opinion. So what evidence do we have for using 100% O2 during chest compressions in babies? Unfortunately, we do not have any evidence. And the only piece of evidence comes from some lab studies where they have shown that when there is complete cardiac arrest and a lamb is receiving chest compressions, whether you use 21% O2, which is shown by the blue line here, or 100% O2 shown by the red line here, the PaO2 is really, really low, despite the use of 100% O2. At the most, you achieve PaO2 levels in the 30 to 40, partly because there is not much blood going to the lungs when there is cardiac arrest, which is delivery to the brain during chest compressions. 21% O2 during chest compressions results in very, very low oxygen delivery to the brain and possibly to the heart. And the use of 100% oxygen results in significantly higher number. But remember, the normal delivery in this particular model is somewhere between 3.7 to 10 ml per kg, and barely we are achieving 1 to 1.5 ml. So the use of 100% O2 during chest compressions is relatively better compared to 21% O2. But when there is complete cardiac arrest, the benefit that you get with chest compressions and oxygen is very minimal, and the PaO2 levels are really low. And for this reason, I do believe that the current recommendations where you increase the FiO2 to 100% when you're doing chest compressions is reasonable. The third question that comes up is once you do chest compressions and give epinephrine if needed, and the baby has return of spontaneous circulation, abbreviated as ROSC here, what do you do with FiO2? Normally what we do now is that during PPV, we initiate a resuscitation with 21% oxygen. When we do chest compressions, we go all the way up to 100% O2. And once the baby achieves return of spontaneous circulation, we gradually wean the FiO2 to target the SpO2 targets given by NRP, and then we bring the FiO2 down. And another method of doing this is to follow the same protocol, but as soon as you see return of spontaneous circulation, abruptly wean the FiO2 down to somewhere close to 21 to 30%, and then titrate up to target saturations. Recently, Dr. Russell again of cardiac arrest and showed that with gradual wean of FiO2, you result in pretty high PaO2 values, almost in the 200 to 250 millimeters of mercury range. And then eventually with weaning FiO2, the PaO2 values come down. On the other hand, if you abruptly turn the FiO2 down to 21%, soon after return of spontaneous circulation following chest compressions, the PaO2 levels remain within physiological range. And so there might be some benefit to abrupt weaning. We do need more trials in humans before we adopt this particular way of weaning. And this is something that needs to be thought out in future studies. What about preterm infants? We talked about term infants until this point. Preterm infants are very different. And the reason for this is that preterm infants have various physiological differences compared to term infants. And in preterm infants, various studies have shown that if the baby does not achieve a pulse ox of at least 80%, or a heart rate of around 100 beats per minute by 2 to 5 minutes of age, the risk of mortality and intraventricular hemorrhage in this particular baby is very, very high. So why is it so difficult to achieve these numbers? The first and foremost is what Dr. Davis mentioned a few minutes ago, mask leaks. It's much difficult to achieve a nice mask seal in a preterm baby compared to a nice chunky term baby. And these mask leaks tend to contribute to low oxygen levels in the alveoli. In addition, the pulmonary vascular smooth muscle in preterm babies is less responsive to oxygen compared to term babies, and the levels of endogenous nitric oxide and the vasodilators can be low. There is also surfactant deficiency in a fluid-filled immature lung that's still in the canalicular stage at 24 weeks of gestation, and that contributes to the same problem as well. More recently, Dr. Ramanathan and colleagues reminded me that there is this entity called a trigeminal cardiac reflex, in which where you apply the pressure on the face, this reflex can lead to a closed glottis and epiglottis and prevent air from entering the lungs. This is something that needs to be investigated. There might be some bradycardia with this as well, but this might be another contributing factor. And hypoxia has been shown to lead to closed glottis and epiglottis also. So all these reasons in preterm babies tend to make them unique, leading to a poor pulmonary vascular transition and respiratory failure during resuscitation. So when you look at the optimal initial FiO2 during resuscitation of a preterm infant, many studies have been done, and there are multiple systematic reviews addressing this topic. And here is a graphic telling you the summary of all these trials. When you compare babies, preterm babies who are resuscitated with less than 30% O2 versus more than 60% O2, overall, the systematic reviews have not shown any difference in oxidative stress or clinical outcomes between these two groups. There are studies that were conducted by Julie Oy et al., where they showed that with the initial FiO2 for resuscitation was 21%, the mortality in a post hoc analysis in babies less than 28 weeks was higher, and I will show this to you in a second. And some studies by Vishal Kapadia and colleagues have shown increased oxidative stress with the use of 100% O2 in babies with in preterm babies. But more recently, Decker et al. Have shown better minute ventilation volumes when the initial FiO2 is 100%. And these two studies require some attention. So let's go through the torpedo study by Julie Oy and colleagues. In this particular trial, when the post-hoc analysis was conducted and looking at babies less than 28 weeks gestation, what they noticed was that if you initiate resuscitation with room air and compare that to initiating resuscitation with 100%, there's 24% death rate in the 100% O2 group, which achieved a p-value of 0.04. Remember, this was not a predetermined analysis and a post-hoc analysis, so the significance of this finding needs to be diluted because of that fact. But interestingly, the main cause of death was respiratory failure. In other words, 8 babies in the room air group died due to respiratory failure, whereas only 1 baby in the 100% O2 group had respiratory failure. And because of this reason, especially in extremely preterm infants, in my opinion, initiating resuscitation with 21% is probably not recommended, and at least 30% or higher O2 sugar group's recommendation. This is the second trial that came out last year, a couple years back, by Decker and colleagues, where they compared preterm infants. It's a small number. They had recordings in only 44 infants, where they randomized them to initiating resuscitation with either 30% O2 or 100% O2 with fairly rapid titration. They increased the FiO2 if the SpO2 was more than 90% and increased FiO2 if the SpO2 was less than 25 percentile. And these changes were made fairly rapidly. And what they noticed was that when you start off with 30% oxygen, these babies had lower minute volumes, longer duration of mask ventilation, lower oxygenation at 5 minutes, prolonged duration of hypoxemia, and lower FiO2 exposure during the first 5 minutes. On the other hand, although you had higher FiO2 exposure in the first 5 minutes in the 100% O2 groups, this group had better minute volumes and shorter duration of mask ventilation with better oxygenation with less hypoxemia. And interestingly, there was no difference in the duration of hyperoxia in this particular study, 8 isoprostanes. These were not elevated with 100% oxygen use, mainly in my opinion, because the amount of time they were exposed to 100% O2 was fairly limited. So if you look at preterm babies, especially those that are undergoing mask ventilation, say you're talking about a 23-weeker or a 24-weeker going